Hello everyone, and welcome to the third in the Royal College of Pathologists Global Antimicrobial Resistance webinar series. Today's webinar is entitled Antimicrobial Stewardship in Secondary Care. My name's Professor Angharad Davis. I'm the Clinical Director for Publishing and Engagement for the Royal College of Pathologists and a Consultant Medical Microbiologist by background. I have the privilege of chairing this series for the college, having previously worked extensively with the international team. So I will be moderating today's session. As I mentioned in previous webinars, almost a quarter of our CPATH members are located outside of the UK, and the purpose of this series is to share experiences in antimicrobial stewardship from our members worldwide and generate discussion informed by different countries' perspectives. So before we get into the presentations for this webinar, I wanted to provide an overview of the series. It's a six-part series which started earlier this month. We're going to deliver a webinar every week until the 12th of July. Every webinar starts with the UK speaker providing an introduction to our topic and outlining the UK perspective. Then we hear from speakers from countries across the world. So the next webinar will take place on the 28th of June, focusing on engaging the public in antimicrobial stewardship, hearing from speakers from Egypt and the United Arab Emirates. Then on the 3rd of July, we'll explore developing prescribing guidelines with speakers from Egypt and India. And on Friday, the 12th of July, at a slightly later time of day, we'll look at evaluating antimicrobial resistance programs. What are the measures of success? Hearing perspectives from Canada, Egypt, and Hong Kong. So this slide shows the link to the college conference webpage where these webinars are advertised. Please bear in mind that if you wish to join each webinar, you need to register for each one individually via the web pages. You can see in the red circle the logo for this webinar series, indicating that that is one of the events of this series. So on to today's session. This is the agenda that we have. We will have the topic introduction and UK perspective, followed by presentations from Cuba, India, Nigeria, and Qatar. And afterwards, we'll have a Q&A session. If you have any questions to ask during the presentations, please do put them in the Q&A box as we go along, and we will answer them all together in the Q&A session at the end of the whole webinar. We won't be taking the questions in between each speaker. We'll keep them all together at the end, but please do enter your questions as you go along. So, to provide our topic introduction and the UK perspective, we have Julie Harris. Julie is a consultant antimicrobial pharmacist working in Swansea Bay University Health Board in Wales in the UK. She leads on the Antimicrobial Stewardship Programme for the Health Board across both primary and secondary care, working closely with microbiologists, clinicians, general practitioners and allied health professionals. She's also an honorary senior lecturer at Swansea University, working closely with the new School of Pharmacy, helping plan and deliver antimicrobial stewardship content. She's extremely highly experienced, and I'm looking forward very much to hearing her presentation. Thank you very much for finding the time to join us, Julie, and over to you.
Thank you for the welcome and the invite as well. I'll just share my screen now. So I'll start off with the introductions and Angharad has said, and then move on to the kind of UK perspective as well. So starting with the why, why do we target hospitals for antimicrobial stewardship? Because proportionally, it is actually quite a small proportion of the overall prescribing that happens across all of the healthcare system. So in the UK, our consumption data shows it's roughly about 20% of antibiotic usage within the hospitals, with the vast majority being in community settings instead. But there is high intensity of antibiotic prescribing within hospitals. The global PPS data shows us that at any time, about 30 to 40% of inpatients are on antibiotics. And there is much more usage of broader spectrum antibiotics, including intravenous antibiotics, which, you know, as people working in stewardship will know, are some of the key targets that we work with. And the global PPS supports that, showing that across the globe, some of the three most commonly used antibiotic groups are beta-lactamase inhibitors, so agents like comoxiclav, piperacillin tazobactam, third-generation cephalosporins like ceftriaxone, and fluoroquinolones, which all are broader spectrum antibiotics that we are trying to conserve within stewardship initiatives. And also there is lots that can be done within hospital to promote antimicrobial stewardship. This is quite a short session today, so I am going to focus on some of the key areas, in my opinion, that kind of form the kind of the basis and the kind of the foundations for any stewardship programs. And that is going to be influencing antibiotic choice by using antibiotic guidelines and restricted access, and also then how we measure antibiotic prescribing within hospitals to know what the baseline is, where we're starting from, and to monitor improvements through the programme, and that's through surveillance, audit and feedback as well. And to have a successful antimicrobial stewardship programme in any hospital, there has to be a degree of governance around that to help ensure that it is prioritised within the health board, within the hospitals, and that everybody is signed up to what needs to be done. And the World Health Organization does encourage all countries now across the globe to develop and implement antimicrobial stewardship programmes at a national level. And at a hospital level, this usually involves formation of an antimicrobial stewardship committee with antimicrobial stewardship champions across professional groups who will work together to produce an action plan that will include a lot of the things that I will run through today. And there are some key documents from the World Health Organization that help hospital and facilities to give some guidance on how to do that as well. We do have to acknowledge that there are barriers to antimicrobial stewardship globally as well. From the UK, I recognise some of these challenges that we are still struggling with. Prescriber beliefs, patient beliefs around antibiotics, staff and resources are a few of our challenges. I have worked previously closely with Malawi, and so I am aware of, you know, some of the additional challenges across the globe around unreliable supply chain, access to antibiotics, laboratory resources, and lack of diagnostic imaging, which all are additional challenges country to country as well. But the World Health Organization is key in trying to push this agenda across the globe, and they have produced a number of useful initiatives around this. And one of the most useful initiatives at a hospital level, certainly, and wider, is their AWARE initiative. This is a tool to help support antibiotic stewardship efforts at both local, national and global levels, and it helps classify all of the antibiotics available into three broad groups, which are access, watch and reserve, with a key aim of trying to promote use of access antibiotics whenever possible within hospitals and facilities, and indeed in the community as well. And the World Health Organization sets a country level target of having at least 60% of all antibiotics used falling into that access group. And in case you're not aware, this is just some examples of the types of antibiotics that fall into these three different groups. So access are generally narrower spectrum antibiotics, which will have less propensity to promote antibiotic resistance. So they are the preferred agents, and whenever possible, they should always be available and used whenever available as well. The middle category is watch. So these then move into broader spectrum antibiotics, and these are agents then you would then want to use more sparingly. They're too precious to use all of the time and should be reserved for the more severe or polymicrobial infections that need broader spectrum antibiotics. And the reserve category, these are our last line antibiotics that are the only agents often to treat some multi-drug resistant infections, and they should be used as a last resort and restricted in that way within hospitals and facilities whenever possible. And so the WHO aware categories form the whole basis really of trying to influence the choice of antibiotics. And there are a number of ways of doing that within hospitals and facilities. Having a formulary in the hospital is one way. So this would be a list of antimicrobials that has been agreed by the Drugs and Therapeutic Committee within the hospital or its equivalent for use within all of the wards. And then there are different ways of using the formulary then to try and help control usage of these reserve broader spectrum antibiotics. In the UK, a lot of hospitals will use a traffic light system where red will be antibiotics that are restricted only for advice from a microbiologist, because we have consistent access to microbiology in the UK. They will be your the reserve antibiotics in the WHO categories. Amber then will be antibiotics that are available, but only for more senior consultant level doctors to use, or specialist doctors whenever they use outside of guidelines. And green will be your aware antibiotics, where there'll be no restrictions, but they will still be expected to comply to the antimicrobial guidelines around choice within that category as well. And that moves me on to the antibiotic guidelines, which is, you know, one of the most key elements of the stewardship programs within the UK and wider as well. And so this builds on top of the formulary and gives more specific advice for which antibiotics should be used to treat specific infection types. How comprehensive guidelines are will differ across different hospitals. It'll differ across different countries as well. But often they are tailored to antibiotic availability and also to antimicrobial resistance patterns, if that data is available for the country. And they will, like the formulary, try and promote use of narrow spectrum access antibiotics whenever possible. But also importantly, will give additional advice on optimizing doses and durations of treatment as well, so that the antibiotics we use can be used as effectively as possible as well. Just some examples of ways we have displayed and disseminated the guidelines in my local organisations. This was a pocket guide we had in use for many years, which was an A5 size, so that could fit in your pocket, but gave all of the kind of information on which antibiotic to use for which infection. And also these were bank card sized reminder cards that we've also used. Again, pocket size, but also gives that information in a concise and accessible way that prescribers can carry around the hospital with themselves to remind of the guidelines as well. Much of the guideline access has now moved to apps in the UK. So I just wanted to draw attention to the Prescribing Companion app, which has been funded by the Fleming Fund until 2027. It has to be accessed at a national level, and they look for app champions then to take a lead for the country in getting guidelines for the country onto the app and editing them as well. But then that guideline access is free for the end users across all prescribers and other health professionals within that country as well. Then moving on to data, because certainly it is one of the most powerful things we can do around driving antimicrobial stewardship forward. Data is knowledge, and then knowledge does lead to power. So access to prescribing data within the hospital in whatever form it can be accessed is really essential to be able to plan hospital stewardship initiatives. It helps understand what needs to be targeted initially. It's also a powerful tool for securing engagement from others, evidencing a problem, and then bringing people together to try and work to solve that problem is what's often needed to promote engagement as well. But importantly, it helps secure that engagement in the longer term as well, by helping to evidence the success of interventions or change interventions if they're not successful through ongoing monitoring, to keep driving change in that way through the programme as well. And there are a number of ways to survey and monitor antibiotic prescribing. At a national level, there is the WHO GLASS programme, where countries can upload antimicrobial resistance and usage data to a platform. And there are now 137 countries enrolled across the globe in this initiative as well. But bringing it back to a hospital facility level, there are also the global PPS tool, which I'll talk about more in a second, is available. But there's also a wealth of information within stock consumption data within hospitals as well that can also be utilised. And of course, there's also clinical audits and feedback within more specific areas, which may be areas identified by the global PPS as needing more targeted intervention. So the global PPS, if you're not aware, is a freely available online tool that can be accessed via the internet. It is an audit tool that is used to do snapshot audits, so one-off audits of antibiotic prescribing, and is available in a web or a paper-based data collection format as well. The inpatient modules have been around for a number of years, but there are now outpatient modules that are able to be accessed as well. And there's lots more information at the web address on the screen if you'd like to find out more about it. But the global PPS is now starting to produce lots of interesting information, comparing and contrasting the different categories of the aware antibiotics across different continents and between high, low and middle income countries as well. And it also is starting to highlight, some of the common issues around antibiotic prescribing that we're seeing globally, and comparing, those issues between high and low and middle income countries as well. And some of these coming from the UK are very familiar. The trying to get good documentation around antibiotics in terms of indication, stop, review dates, so that antibiotics can be effectively reviewed in timely manner. Driving compliance to prescribing guidelines are issues that we work on day to day here, but also, more from a lower middle income country as well, the, reliance because of supply chain issues on certain classes of antibiotics and how that can then drive resistance is also coming through in this data as well. And so at a facility or hospital level as well, there is usually some forms of inventory of pharmacy stocks of antibiotics and usage of antibiotics, and that can be a useful system to tap into to try and get a more consistent view of how much antibiotics are being used in the hospital and which types of antibiotics are being used as well. So whether the system is electronic or a paper format, that data can be collated and used in that way. And it's also often useful to track changes in more real time and a more consistent and regular basis that can be achieved by the global PPS, which is quite a resource heavy undertaking and so can't be taken, and so it's often done kind of intermittently rather than regularly as well. So I'll move on now to the UK and Wales perspective. So I'm working, as Angharad said, in Swansea within Wales, which is a small proportion of the UK that you'll see highlighted in the darker green on the map there. But much of what I will outline of what we do in Wales will be very similar to what happens in the rest of the UK, in England, Scotland and Northern Ireland as well. So as per World Health Organization recommendations, we do have an UK National Action Plan on confronting antimicrobial resistance, and the second 5-year proportion of that plan has just been published last month. It is now very much a One Health approach in the UK. So as you'll see from the contributors to the paper, agricultural and veterinary use of antibiotics is very much alongside human health now, as well as the industry around promoting research and new access to new antibiotics as well. We do have new targets within human health, and that is to reduce our overall consumption by 5% across all health sectors, and to increase our access category use to 70%, which is a little bit more challenging than the World Health Organization target of 60%, but we don't have access problems to antibiotics, and so that additional challenge is justified. And the whole premise and the kind of gold standard approach to antibiotic prescribing in the hospital is driven by this document from the UK government called Start, Smart and Focus. And what this is an evidence-based approach to optimum antibiotic prescribing. And what it recognises is that antibiotics often have to be started quickly, especially in the sickest patients, and that often there's not all the information available about the source of the infection or what's causing the infection. But it needs to be done in a systematic way, ensuring that there's samples sent to microbiology before antibiotics are started, and that guidelines are used and that there's good documentation around the prescriptions as well. But the second part is then ultimately a really important part as well, the then focus bit, because recognising that sometimes that having to start without a lot of information is key in this element, that within the first 2 to 3 days of starting an antibiotic, this approach then recommends that there is a full review of that prescription undertaken to ensure that the initial diagnosis has been confirmed, and if infection has been ruled out, the antibiotic is stopped. If there's a need for ongoing antibiotics, can those antibiotics now be amended and tailored, switched to oral if they were IV to begin, to targeted to culture results, or referred out for to community services if possible as well. And so this is the kind of toolkit we all work on within hospitals within the UK. And of course, antimicrobial guidelines are key in that approach around the initial choice as well. They are now all electronically housed in the UK via internet links and mobile apps as well, and they are routinely used across all UK hospitals. The content is based on NICE guidance and the UK guidance whenever available, but is then adjusted for any local antimicrobial resistance patterns and local challenges as well. And guidelines in the UK tend to be very, very comprehensive. They will also cover kind of guidance on diagnosing infections, severity assessment, appropriate microbiology sampling, and will include multiple choices to cover penicillin allergies and other allergies, advice on what to switch IV antibiotics to, and the optimum duration based on the evidence base as well. But one thing we do still struggle with in the UK is around getting IV antibiotics switched to oral in a timely manner, and that is usually for the vast majority of infections in the last 2 to 3, within the first 2 to 3 days. But there are much misconceptions that still exist, you know, in the UK and globally, I'd imagine as well, around, you know, that there isn't a need to switch to oral until patients are ready to go home, that IV antibiotics are always better than oral. There are many oral antibiotics with very good bioavailability that's not true for, and that the same agent has to be used both IV and oral as well. Again, which is a misconception, because you can safely switch to alternative oral antibiotics, and we are developing our guidelines locally to ensure that we try and bust these myths and try and encourage oral switching whenever possible. And that's because there are real big benefits to early IV to oral switch, both at an organisation level and a patient level as well. Oral antibiotics are much easier to administer. That saves nursing and medical time. They're often less expensive than IV, and there's a much reduced risk of administration errors by giving tablets or capsules rather than intravenously as well. There's a big push on the green agenda in the UK and reducing plastic use. And of course, oral forms are utilise much less plastic waste than the IV forms, where you've got bags and lines, which are single use as well. And there's obviously there's big benefits for the patient as well. The oral therapy, particularly, you know, further into their infection course, is as effective as IV as well. They can have their IV cannulas and lines removed, which improves their comfort, their mobility, and reduces the risk of complications, including bacteremias as well. And it often facilitates earlier discharge from hospital, which is within everyone's benefit as well. And so what we try and do to promote guideline use and Start, Smart and Focus and IV to oral switch is utilise the inpatient prescribing chart. to try and put a focus on this as well. And we're fortunate in Wales that we have one common prescribing chart that is used across all of the Welsh hospitals. So that helps with familiarity from prescribers as well. And what we have worked hard over the last kind of few years is around getting a dedicated antibiotic section on that chart so we can ensure that antibiotics are prescribed differently to all the other regular medication, and we can promote some of these things I've been talking about within the session. So the chart will ask for a documented indication and stop review date for all antibiotic prescribing. It will ask prescribers to include the basis for their prescribing, whether they're following guidelines, whether it's based on microbiology culture results or direct advice from microbiology. It will promote that all-important review at 72 hours, and it's got limited administration sections to make sure that antibiotic prescriptions don't continue for weeks unreviewed, and so they are shorter than the regular medication sections. They were 7 days previously, but we have now moved on to a new version of charts in Wales, which has a 3-day administration section only. So all administrations are signed off by the nursing staff, and so you will see there's only space there to sign for 3 days before that prescription has to be stopped and re-prescribed if it needs to continue. And this was based on a very large research study in the UK called the Antibiotic Review Kit that we took part in locally, but there was about 40 sites across the UK. And what that did was looked into interventions that would help improve review of antibiotics by 72 hours, and by improving that review, then lead to a safe reduction in antibiotic prescribing, as antibiotics that are no longer needed are recognised quicker because of the increased review and stopped in a more timely basis as well. And so that is where this chart has come from, and it is now used across all hospitals in Wales. And our local data show that it produced a 10% reduction in the numbers of prescriptions of antibiotics stopped within the first 3 days through that increased review. And the overall study across all sites showed a 5% reduction in antibiotic usage across all of the hospitals involved. And so it was proven to be a successful intervention. In terms of monitoring and surveillance as well, so we do regular point prevalence surveys that are based on Start Smart and Focus. So we look at documentation, compliance to guidelines, and that review with 72 hours. We're fortunate that Public Health Wales provide us with a online tool that we use across Wales, and so that also allows us to compare our results from these regular audits to other areas of Wales against the Welsh average, that we can benchmark. And then if we find we are outliers, we can then use that information to drive improvements within our own local organisations. We also use consumption data in the same way as I outlined earlier on in the presentation. Our data is electronic, but it's captured from pharmacy computer systems. It is then processed by Public Health Wales and is then available via a digital portal for us to access. Data is presented in defined daily doses so we can compare between antibiotics, and we then adjust for activity within the hospitals by using admission rates as well. So that allows us to better compare hospital to hospital, even a large hospital to a smaller hospital in terms of activity, but not for case mix. And this information we have available via this portal is really useful for all our stewardship programmes to be able to monitor trends over time within our own hospitals, looking at access versus what's reserved, looking at how much IV antibiotics are being used. But just as importantly, it also allows us to compare our practice within our local hospitals, other hospitals in Wales, and look for areas where we need to improve and drive the antimicrobial stewardship programmes in that direction. This is just an example of one of the graphs from that portal, looking at access use within 2 of my local hospitals and comparing that against the All Wales average, which is the black line there. And you can immediately see where the focus needs to be around access, improving access antibiotics then. So thank you for listening. That is the end of my session, and I will pass you back to Angharad.
Thanks very much, Julie, for that fantastic and comprehensive overview of antimicrobial stewardship in secondary care. Really great summary of practice here in the UK. Thank you very much. So we're now going to hear the Cuban perspective from Dr. Rebecca Perez. Dr. Perez is currently a consultant clinical microbiologist at Hamad Medical Corporation in Qatar, but previously she was a clinical microbiologist and auxiliary professor and researcher at Pedro Curie Institute of Tropical Medicine in Havana, Cuba. So it's a great pleasure to welcome her, and thank you very much for joining us today, Dr. Perez. Over to you.
Okay. Good morning, good afternoon, good evening, wherever you are. Thank you to my microbiology doctor in Qatar for her help. Thank you, Guy, for your guidance. Thank you, Royal College of Pathology, for giving me this nice opportunity. As you can see in my slide today, I'm going to talk about antimicrobial stewardship from secondary healthcare, Cuban perspectives. And my main objective with this presentation is to describe how antimicrobial stewardship is carried out in the secondary healthcare institution of Cuba. And for that purpose, I'm going to give you a very brief background, but of course, I'm going to focus it in how antimicrobial stewardship is carried out in secondary healthcare of Cuba. Let's start by highlighting the interconnection that exists between antimicrobial stewardship and antimicrobial resistance. All we know that antimicrobial resistance is a serious global challenge that can occur in both hospital and community. And this is a big complaint about what is happening in hospital with severe infection caused by resistant mechanism, because it are responsible for high morbidity and high mortality. To fight again antimicrobial resistance is when antimicrobial stewardship came like one way to fight against antimicrobial resistance. And it is because antimicrobial stewardship includes some strategy, but the main component of antimicrobial stewardship is the quality of antimicrobial prescription. We know that in 2014, CDC from USA released the core element. This document was updated in 2019, and this is based on a structural and procedural component to guide the implementation of antimicrobial stewardship at hospital. What happened in Latin America? Latin America, according with the point prevalence surveys of antibiotic use, it showed a high rate of antimicrobial resistance, and also a hospital framework characterized by exaggerated prescription of high spectrum of antimicrobial, mainly third-generation cephalosporin and quinolone, and also prolonged surgical prophylaxis. In this slide, you can also see the different effort of different countries of Latin America to implement different components of antimicrobial stewardship to confront the antimicrobial resistance. Cuba is an island, is a country that is located in the Caribbean region of Latin America that have about near to 12 million inhabitants. I would like to give you some data about antimicrobial resistance in Cuba. Note in this side, the global data, look at where is antimicrobial resistance, and according with the global reserve of antimicrobial resistance, Cuba, in the Caribbean region, Cuba has the second lowest standardized mortality across 19 countries. Another data is related with the placing of antimicrobial resistance with other cause of death. And look at this, like antimicrobial resistance, the number of deaths is higher than other conditions like neurological disorder, diabetes, etc. I also want to remind some pathogens that should be aware because are related with deaths associated with antimicrobial resistance. And these are Acinetobacter baumannii, Staphylococcus aureus, Streptococcus pneumoniae, E. coli, and Klebsiella pneumoniae. All of these are related with a severe infection of bloodstream, of lower respiratory tract, abdominal infection, and this is why it should be taken in a ward. So how antimicrobial stewardship is carried out in Cuban secondary healthcare? Well, first of all, I would like to share the organization of our healthcare. Our healthcare, as others, have 3 levels, and secondary care about the presence of hospital. And according with the Cuban official website of the Ministry of Public Health, in Cuba there is 152 hospitals with 36,719 beds. The movement of the narrows means that the examples are sent into the national reference labs in order to identify the different mechanisms of resistance, and then the feedback is sent into the different organizations. Which is the national regulatory framework for antimicrobial resistance in Cuba? First of all, we have a national drug program that have some important characteristics. For example, there is a identification of the prescriber with a personalized stamp, also a control with a foliated prescription, and the quantity is differentiated according with the level of the hospital. There is also regulation with the prescription of some certain antibiotics, as well as the single medication per prescription. In our basis table of drugs, antimicrobial represents 16.5%. The other point is the presence of a regulatory authority that belongs to our Ministry of Health that control the drug safety and register and authorize the marketing of medicine, including antimicrobial. From the antibiotic prescription to antibiotic administration to the patient, there are also other hospital regulatory framework that I'm going to comment. For example, the pharmacotherapeutic committee is included the authorization level of the antibiotic, and it is included in the antimicrobial prescription policy, as well as the antibiotic classification that is included in antimicrobial dispensing policy. Antibiotic subcommittee is the one responsible with the antibiotic policy, and hospital pharmacy control the prescription that is authorized by antibiotic policy. So let's near to how antimicrobial stewardship works according with the extractor, processor, and later with the result. In the hospital, we have a different committee, pharmacotherapeutic committee, infection and control committee, antibiotic committee, microbiology lab, that develop some important functions, some important role that were in a coordinated way, in collaboration way, and this committee assumed the function of antimicrobial stewardship. I'm going to highlight the interconnection that exists between antimicrobial antibiotic committee and antimicrobial data in the optimization of antimicrobial use. As you can see in this slide, antibiotic committee is a committee that includes a multidisciplinary team, and it's very important that this team were in the optimization of antimicrobial use. For example, different actions are developed inside of this committee. For example, the analysis of the patient data, the analysis of antimicrobial sensitive or resistant that are showed by microbiology data. They making decision about the use of antibiotics, important action in the escalation or de-escalation of antibiotics when necessary, Also regulate the use of strategic antibiotics, and very important point is the communication of prevention measures to epidemiologist members. I want to highlight also the important information that microbiology lab informed for this committee. I'm talking about the grand stain in which from this information, it is a preliminary report that support the empirical treatment, and final, the isolated microorganism and the sensitivity and resistance pattern that can allow to escalate or de-escalate when the patient data is analyzed. Now I'm going to show you some example of antimicrobial stewardship. For example, let's start with microbiology, because microbiology is the one who sends the information of the microorganisms that are present in the infection of the patient. I just want to mention the different role that microbiology labs develop in the quality control of lab results, in the interpretation of microbiology data. It's very important to report the narrow spectrum antibiotics, the clinical and epidemiological analysis of antimicrobial resistance from data stored in the antibiogram, the surveillance of resistant pattern of microorganisms, as well as educational activities. These all are the different roles that microbiology, clinical microbiology develop in order to support antimicrobial stewardship. Then I'm going to show you some results about the monitoring of antimicrobial resistance. For example, as a result of the National Reference Lab, there is a circulation of Enterococcus species resistant to glycopeptides, also low prevalence. A significant circulation of methicillin-resistant Staphylococcus aureus in situations like that exist in other countries of Latin America. We also have circulation of gram-negative pathogens that can produce KPC, type of carbapenemains, and also high prevalence of ESBL producing E. coli and Klebsiella pneumoniae at national level. These are some reports of surveillance of resistant microorganisms. In this slide, you can see the monitoring of E. coli extraintestinal. As you can see, there are high percentage of resistance of cephalosporin of third and fourth generation cephalosporin. As well as this other study in which this is a study of 4 provinces of Cuba, in which we also see the producing of carbapenemains from E. coli isolate. Now I'm going to show you some data according with monitoring antimicrobial prescription. In this study, in which 641 antibiotic prescription was analyzed, we obtained that a 32.3% of the antibiotic prescription was incorrect. On the other hand, penicillin and cephalosporin was the antibiotic with high rate of incorrection prescription. And these are the different diseases that were related with this prescription. Now I'm going to show you some example about monitoring antimicrobial consumption. This is a study that were performed in Holguín, one province of our country. As you can see, a high consumption of cephalosporin, as well as the municipal hospital were the most related with this result. Now I want you to show you an implementing intervention in order to fight against antimicrobial resistance. In this case, the intervention was an evaluation of quality prescription, feedback information, educational activities, the operation of an antibiotic committee, implementing protocol of antimicrobial drugs, and you can see that the proportion of inadequate prescription of antimicrobial were done in this study. I want to show you also another study, another implementing intervention, the same intervention, in order to measure the economic effects. As you can see, the cost of the antimicrobial use declined in this study with this intervention, as well as the consumption of cephalosporin and fluoroquinolone. So this is an example in which that show that when we use intervention, we can reduce the use of antimicrobial. Now I'm going to show you some educational activities that we realize in order to update the different staff with the correct use of antimicrobial. As you can see, we have a master DC in our institute that specialize our professional in infection disease and tropical diseases, and this of course help into correct use of antibiotics. I also want to show you this slide. This means that in February, from 11 to 15 in 2019, it was the first international workshop in which different professionals from different institutes assume the antimicrobial resistance with different point of view, with a point of One Health. And this is the last national workshop of surveillance of control of pathogens related with healthcare associated infection, in which all the specialists from all the countries of from all the provinces of our country receive updated information about the different resistant mechanisms, as well how to use in adequate way the antibiotics. I want to share with you different vulnerabilities, strengths, and challenges that we have regarding with antimicrobial stewardship. Weakness in the way of a structure, we need to enhance in leadership commitment. Another weakness is that we have an irregular supply of antimicrobial to the hospital network, and as well as the insufficient use of the technologies of information. As a process, we consider that we have a weakness, consider inappropriate use of guidelines which lead to the inappropriate prescription of antibiotics, as we see in the previous slide. And in outcome, we have insufficient study of antimicrobial consumption as a measure of point prevalence, as well as a cost effective of antimicrobial use, as well as other outcome indicators. As a strength, we consider that Cuba national healthcare system that is universal, free, public, and decentralized is one of our strengths, as well as specialized human research that can assume different functions in the different hospital committee. Another strength is a network of hospital microbiology labs that are interconnected, that receive feedback from national microbiology lab, the organization of health service that allows timely information and feedback, and the functioning of other hospital committees. As a challenge, we need to extend and to strengthen the antimicrobial stewardship committee in those hospital institutions that do not contribute with result to the health system, to achieve the adherence for the member of the committee to implement new antimicrobial stewardship intervention, and to guide the work of the committee to document possible clinical results that are essential to be measured in the medium of a long term. As a conclusion, Cuba secondary healthcare facility take on the challenge of implementing antimicrobial stewardship program with limited research. Several strategies that document the implementation of antimicrobial stewardship program are presented, and these include, from the structure, a team of specialized health professionals who belong to several hospital committees and who assume the function of antimicrobial stewardship program. on the process, optimization of antimicrobial use, monitoring antimicrobial prescription and consumption, implementing intervention, including the cost evaluation, as well as educative activity to prescriber and other professionals of health system. And as outcome, we have still insufficiencies in the quality of restriction and high consumption of antimicrobial. The intervention strategy implemented improves both outcome and reduce hospital costs. And at the end conclusion, greater efforts are needed to extend and strengthen antimicrobial stewardship program in hospitals that do not report results, as well as the incorporation of new proactive strategies that impact in the quality of patient care. Back to one of my first slides, in which I said that the quality of prescription is the main component of the different strategy of antimicrobial stewardship, and it needs coordination and collaboration. All of this remind me the teamwork, and this is why I want to finish with this phrase. It is not a question of how well each process works. The question is how well they work together. Thank you very much.
Thank you very much, Dr. Perez, for that extremely interesting presentation covering antimicrobial stewardship in Cuba. I found that fascinating. Thank you so much. I'm going to share my screen now to go on to introduce the next speaker. So our next speaker, I will introduce in a minute. I just wanted to remind you that if you have questions for any of the speakers, please do put them in the Q&A as we go along. You're welcome to type them in now and we will come to them at the end. So don't forget to put your questions in the Q&A. So it's a pleasure to welcome our next speaker, who is Dr. Ranganathan Iyer, speaking from Hyderabad in India. Dr. Iyer works at Gleneagles Hospital, Rainbow Children's Hospital Group in Hyderabad in India, and he's the Royal College of Pathologists Associate International Regional Advisor for Southeast Asia as well. So thank you very much for joining us, and we look forward to hearing your presentation. Thank you, Dr. Iyer.
Thank you so much, and good afternoon, everyone. Good morning to those in Western Europe and in the UK. Just try and share my screen in a minute. Yeah, I hope
that's it. We can see them. Thank you.
Yes, thank you so much. Well, it's a great pleasure to be a part of this webinar on antimicrobial stewardship in secondary care and how we have gone about this major task in India at the moment. Well, it would suffice in a 10-minute presentation to talk about the challenges that we face, what may be done to circumvent the challenges, and to give certain examples, a couple of examples to substantiate the fact that there has been a lot of work by institutions in India to circumvent the challenges posed in instituting, implementing, and monitoring antimicrobial stewardship in secondary care hospitals and secondary health care. Well, the levels of healthcare were set up long before India became independent in 1947, with particular reference to the tertiary healthcare, the medical institutions and the university teaching hospitals, which had already come up by that time, the primary health centers, that's the primary care, and the district general hospitals. There were a few district general hospitals in major districts across the country in the year 1947, but a lot of this has evolved along with the primary health care over the years, over the last 75, 76 years. Since 1947. And right now we look at three levels of healthcare in India. The primary healthcare, which essentially consists of the primary health centers. The secondary healthcare, which is mostly taken care of with the district general hospitals, which are usually about 200 to 250 bedded hospitals, and the community centers at the block or the regional levels. The tertiary care centers are the medical institutions which we also refer to as medical teaching colleges and the university teaching hospitals. A good number of them are free for service, which also cater to the population at large. In addition to this, we have something called as a private corporate sector that has evolved very much over the last 25 years in the country. And this accounts for almost, they cater to at least about a third of the entire country's population. And those are the hospitals. They're tertiary care hospitals, but many of them may not be teaching hospitals. Some of them are. And they have a payment to be made for the medical services that are rendered at these institutions. Now, what are the major contributing factors for antimicrobial resistance? At least in India, there are two major things on which the AMR problem hovers around. One is the overuse of antimicrobials in humans. That's because we do not have a very well-regulated pharmacy in India. It is possible to go ahead and buy antibiotics and antimicrobial agents across the counter. If you have the money, you also can go ahead and buy the antibiotics across the counter in a pharmacy in any part of the country. There is an overuse of antimicrobials in animals and animal husbandry, as well as there is an expansion of sewage into the environment, and most of this comes from hospital waste and many other types of waste that contributes to the increasing population of microorganisms, many of which are multi-drug resistant organisms. And this calls for an easy transmission of antibiotic resistance or antimicrobial resistance from one bug to another, and from there to human beings and to animals as well. There is an increased transmission of multi-drug resistant organisms between patients, from one patient to a healthcare worker, and from there to another vulnerable patient. And all this can happen in our hospitals, be it the secondary care district general hospitals or even some of the tertiary care hospitals, because of lack of space and sometimes inadequate poor infection control practices. So infection control and prevention practices are of paramount importance if one needs to curtail the transmission of multi-drug resistant organisms, and curtailment of multi-drug resistant organism transmission becomes even more important and vital if one needs to have a fairly effective antimicrobial stewardship program in a developing country like India. So these are the challenges to implementing an antimicrobial stewardship effective program in the country. The first thing is the diversity of the healthcare system in the country. The second thing is we do not have too much of data at the national level. There is a lot of data at the regional level. There is a data in every state of India. But overall, there is a scarcity of data. If one looks at national data, it's not so very well computed. There is a problem with the supply chain and the regulation and the sale of antibiotics. As I've already alluded to in the previous slide, it is possible to go ahead and buy antimicrobial agents and antibiotics over the counter in any pharmacy across the country. There is a problem with professional awareness and an inclination to change, both among healthcare workers, the doctors, the nurses, pharmacists, as well as patients themselves and the relatives of the patients, particularly the parents of sick and ill children, who would do anything to just get their children well, up and about, and go back to school. So the first and foremost thing that is generally asked of a doctor is, isn't it possible to give some antibiotic so that he gets well very fast? There is a lack of laboratory diagnostic facilities, particularly at the primary and the secondary healthcare level. It is not as well developed as it should be or as it is in a tertiary care center. So when the laboratory diagnostic facilities of microbiology and serology and molecular diagnostics are not optimal, one can imagine the fact that there would be a lack of antibiogram, and if the antibiogram itself is lacking, then obviously there is a problem with developing an antibiotic policy. So it's almost like one leading to the other, and that's what happens in the secondary healthcare in a country like India. In addition to this, there is always a shortage of staff, particularly in the district areas. So it may not always be possible to have dedicated staff and multidisciplinary teams. So one person may have to double up and do a lot of work and also cover for all those other people who are not able to give time and energy to implementing antimicrobial stewardship programs in secondary healthcare. And the last but not the least is, of course, the leadership. In fact, that should come first, because if there is no commitment from the top, nothing percolates down. So there is a problem with the leadership as well. So these are some of the challenges. But then if we have challenges to AMS implementation, how could we circumvent this, and what could be done to circumvent this? The most important thing is to have ground level multidisciplinary teams and healthcare workers and build capacity at the ground level, at the grassroots level. And that is very, very important in a country like India. There is a lot of work being done. There is a concerted effort by the Indian Council of Medical Research, by the Ministry of Health and Family Welfare, Government of India in this direction. But then a lot more needs to be done. Lots more needs to be done to achieve a better implementation of antimicrobial stewardship, particularly in the district areas in this country. It's not enough just to have teams, but then one must have very good educational resources so that a lot of knowledge, a lot of awareness can be imparted to people who work at the district levels and who work at the secondary level healthcare. India is a diverse country. There are many languages spoken with many dialects in those languages. So one must have educational resources, not just in English or in the national language, which is Hindi, but then one may have to have it in the local languages, and it is very important for this to be done if we have to have more and more people to understand these educational resources and take them forward in implementation. It is equally important to enhance laboratory diagnostic facility and capacity, but then this is expensive sometimes, and it may be cost constraints may preclude the establishment of very good laboratory diagnostic facilities at the district levels. But then a lot is being done with the aid of the Government of India as well as some of the non-governmental organizations. Patients must be educated so that they accept antimicrobial stewardship and they do not demand antibiotics to be prescribed to them, because as I've already told you, it is possible to go ahead and buy antibiotics off the counter in a pharmacy. So why not give me an antibiotic? Tell me what I need to go and buy, and I shall go and buy it. Now that's generally the level of awareness among patient relatives. It is equally important not just to have physicians and microbiologists everywhere. You may not have very good clinical microbiologists functioning at the district levels or at the district general hospitals. It is very, very important to empower nursing professionals and clinical pharmacists at all levels in the country. Last but not the least, one must have intra and interdisciplinary collaboration so that people do not say, this is not my job or my job ends over here. Our job doesn't end anywhere. If we have to take AMS implementation and put things in a proper perspective in our secondary care. This has been achieved, and I'll just touch upon two examples to justify how many places have circumvented these challenges and have been able to implement antimicrobial stewardship to a fair degree. This was a study from CMC Vellore, the Christian Medical College Vellore in the south of India. They took up antimicrobial stewardship implementation at 4 secondary care hospitals, which were geographically spaced. One was a Padar hospital in Madhya Pradesh, which is central India. There was a Baptist Christian hospital in Assam, which is towards the east of India. Christian Fellowship Hospital in Tamil Nadu, which is down south. and the Bangalore Baptist Hospital in Bangalore, which is also down south, but then it's not as down south as the Christian Fellowship Hospital, which is in a place called Odanchatram, which is very, very down south, almost touching on to Kerala and the tip of India. The facilitating tertiary care center, of course, was the Christian Medical College, Vellore, in the south of India. This was a very successful program, and it has been published. They divided the entire phase of this implementation into 3 phases. A baseline phase, which was basically used to gather information as to what's happening in those 4 hospitals before they even attempted to put in any interventions. Then they put in the intervention. So during the baseline phase, they looked at what were the patterns of antibiotic use, what were the common indications for which antibiotics were being used, what was the prevalence of multi-drug resistant organisms in each of these hospitals, and how many antibiotics and what was the consumption of these antibiotics in the form of DOT or days of therapy. This data was in general taken up at the baseline phase in all the 4 hospitals, and then they intervened. They picked up physicians, nurses, pharmacists, and they trained them. They trained the physicians. They included a nursing professional. They included a clinical pharmacist, and they also tried empowering laboratory skills, setting up certain rapid diagnostics, setting up good blood culture diagnostics. And this was empowered by the tertiary care laboratory facility, which is one of the best in the country at the Christian Medical College, Vellore. The antibiogram development came up once the laboratory skills were empowered, and the WUNET program, which is the WHO program for putting up an antibiogram, was used, and institution-specific, that means hospital-specific antibiograms were made available at each of the 4 centers which were selected. And this was supported from the local administration, who provided the necessary infrastructure and know-how. And that was so very important in the successful implementation of this program. So finally, after the intervention was done, the effectiveness of this intervention was measured over the next 8 months in the form of what were the diagnosis of common infections that were made, what were the patterns of antibiotic use, were the common indications for use followed and adhered to, and how and what was the prevalence of the multi-drug resistant organisms at the baseline phase and at the post-intervention phase. So each of these parameters were compared between the post-intervention phase and the baseline phase. So what were the major achievements obtained in this study? The antibiotic use was found to be much better used. Antibiotics were much better used for a definitive infection at the post-intervention phase, which was much more as compared to a probable infection, as compared to the antibiotics, which was just randomly used for an unresolved diagnosis in a patient who came in with PUO or pyrexia of unknown origin. The second one, which was 77.7% of locally placed physicians underwent training, and they gave advice for antibiotic use in these hospitals. And that was a major achievement from the baseline phase, where just about 10 to 15% of the locally trained physicians could give advice for antibiotic use for commonly encountered infections. The rate of de-escalation of antibiotic therapy from empiric to definitive therapy increased from 12.5 at the baseline phase to 44.4. It still was less than 50, but then it was a major jump that was achieved in the post-intervention phase. The prevalence of multi-drug resistant organisms dropped from 14.5 to 11.1%. Now, this is not a very sharp drop, but then India is a country where we are endemic for multi-drug resistant organisms, particularly the gram-negatives like Klebsiella pneumoniae and Acinetobacter baumannii calcoaceticus complex and so on, particularly the carbapenem resistant organisms. So it may not be always possible to achieve a drastic reduction in the prevalence of multi-drug resistant organisms. Education and training was sustained. And this was a major achievement because it is all very well to give a lot of education and training at the beginning, but then after some time, if it tapers off or wears off, then there's not much to be achieved. It has to be sustained, and that sustenance was maintained with constant reinforcement and supervision. And all of this was because of a multi-pronged approach with education, training, guideline development and formulation, enhancing the laboratory facility at all the 4 hospitals with a prospective audit and a feedback to all the 4 institutions and people who worked in those institutions. The teaching was done with both online and interactive modules. A couple of times, on some occasions, those physicians were called upon to Vellore and given hands and case-based training with deep study for the physicians, and all of this helped in reducing unnecessary antibiotic use. The justified empiric antibiotic use was found to be close to 80%, which was a very, very good improvement as compared to the baseline, where they found just about 20 or 21% of justified empiric antibiotic use. And the overall consumption of antibiotics reduced in all the 4 district general hospitals or in the secondary healthcare institutions. So this was from so this was a major achievement, and this was a hub and spoke model, which shows that it is possible to circumvent some of the major challenges that we face in instituting and implementing antimicrobial stewardship in secondary healthcare in this country. Even more inspiring, even better than the previous one is this antimicrobial stewardship implementation in a palliative secondary hospice. TIPS is one such institution, which is Trivandrum Institution of Palliative Sciences. And this represents palliative care. It represents Pallium in India, which is a charitable organization in palliative care, education, and patient care. Trivandrum happens to be the capital of Kerala, which is right at the southernmost tip of India, God's own country. Anybody who comes visiting Kerala as a tourist would never, shouldn't miss going to Kerala and visiting those beautiful backwaters, the lagoons, and live-in houseboats. This was a 13 to 15 bedded unit with secondary level care with outpatient clinics, where patients with life-limiting illness in the form of end-stage cancer, end-stage diabetes, and chronic kidney diseases were admitted and cared for. A quarter of these patients have always been on at least one antibiotic, whether a documented infection was available or not, whether it was proper to use an antibiotic for their so-called infection, or whether it was improper to use antibiotics for a so-called undocumented infection. The use of antibiotics was also varied, and all of this triggered the physicians working at TIPS in Trivandrum in Kerala to take up this particular ASP package. So they also divided this into a baseline and an intervention phase. The baseline showed various problems that already existed at the Trivandrum Institution of Palliative Care in the form of inconsistent documentation of antibiotic use, which means antibiotics were just prescribed without any documentation, without writing it down, no dose, no duration, no frequency were being mentioned in the case sheets. Now that was inconsistent documentation, and there was no way of knowing who's giving what antibiotic to which patient. Many physicians did not have any access to standard use guidelines. There was no obvious auditing of antibiotic prescriptions and no order form for the pharmacy to audit anything. So in the intervention phase, this particular unit collaborated with the University of Iowa. They formed an interdisciplinary committee consisting of physicians. They selected nursing professionals and clinical pharmacists. They appointed clinical pharmacists. They made an antibiotic order form and implemented it. They picked up various guidelines as well as locally available antibiograms, and they made prescribing guidelines. They selected a local champion for antimicrobial stewardship who would collate information with analysis. There was a lot of online modules as well as face-to-face modules that were used for educating and training physicians, nurses, and clinical pharmacists. Laboratory enhancement was called upon from some of the locally available laboratory medicine departments, particularly microbiology and serology, from the Trivandrum Medical College, which is an age-old institution, and the diagnosis of various infectious conditions was made in this manner. Topical antibiotics, which were majorly used for these patients, they were monitored for their use, and of course, a concordance rate was worked out. So the major achievements at TIPS, they found that 9% of 7,450 patients who were enrolled in the study received antibiotics, but topical antibiotics were right at the top of the list with topical metronidazole. I'm sorry for the typo error over there. It's metronidazole, Z-O-L-E and not E-L, which accounted for 44%, followed by the penicillins, and that accounted for a majority of prescriptions. This is basically used to counter non-sporing anaerobes that lead to a foul odor from open wounds in end-stage cancer patients. Fluoroquinolones were removed from the pharmacy. That's because it was recognized that fluoroquinolone resistance can develop even when patients are on therapy. In addition to that, there can be a collateral damage to beta-lactams and many other beta-lactam lactamase inhibitors with rampant and irrational use of fluoroquinolone. So it was removed from the pharmacy. 32% of antibiotic order forms were documented and they were implemented and adhered to. Almost 70% of these reflected concordance with the prescribing guidelines that were made. To begin with, it was less than 30%, but then it rose to 78 to 80% at the end of the intervention phase. And 84% of the antibiotic order forms did meet the criteria for analysis. And this is a pie chart which gives what were the antibiotics that were majorly being used and to what extent. So as you can see, almost 50% of these were either quinolones, penicillins, or they were metronidazole. So to conclude, we really need well-coordinated, integrated, and context-specific approaches are needed in India to strengthen antimicrobial stewardship in secondary care hospitals. Now, this is a very important set of hospitals because any patient who doesn't respond to primary health care at the PHC level is referred to a secondary care district general hospital. And if the antimicrobial stewardship is not well implemented at this level, then obviously we have even more problems to encounter and grapple with when these patients are referred to a tertiary care medical institution or teaching hospital. The interventions have to be based on local needs. We have to take care of what is available to us in the form of resources and how well and how usefully we could employ these resources and help them strengthen our AMS approaches. It's also equally important to recognize nursing professionals and clinical pharmacists as very important pillars of strength in implementing antimicrobial stewardship at the secondary care level. Laboratory enhancement towards a better diagnosis definitely assists in definitive therapy. And without a good diagnosis, one would just be shooting darts in the dark without a definitive therapy. It's always empiric therapy or preemptive therapy, or there would be no, there's no way of judging whether we are on the right track or one is using an antibiotic for an unwarranted, undiagnosed infection, which could just be a pyrexia of unknown origin without a diagnosis. So laboratory facilities must be very well developed at all levels. Guidelines must be tailored to the local needs. It's not enough just to take IDSA guidelines or ECMID guidelines and say, I will implement the whole of this in a district general hospital in India. But then effectively in both the cases, as in Trivandrum in Kerala, as well as the Christian Medical College, Vellore, they have very smartly taken up guidelines and tailored them to the local needs of those 4 hospitals or 5 hospitals, including the palliative care one. And of course, finally, one must have a very good system for collating, analyzing data with some statistical inputs. And that is when one would be able to understand what is the comparison between what was available at the baseline level and what has been achieved once intervention was taken in, or our post-intervention scenarios. So it's very important to compare this, and unless one has data collation with an analysis with some statistical significant inputs, it becomes very difficult to understand where we actually stand. This is just to give a bird's eye view on the antimicrobial stewardship implementations, facilities created in secondary healthcare in India. There are a few other ones, but then for the want of time and to stick to some amount of brevity, I just thought I would justify giving two examples on how one could circumvent our major challenges in this country. Thank you so much.
Thank you very much, Dr. Iyer, for that perspective from India. Really great to hear from your part of the world. So thank you very much. Everybody, please remember to keep putting your questions in the Q&A if you have any, and we will come to those at the end. Now, our next speaker, who I'm very pleased to welcome, is Dr. Kenneth Iregbu. Dr. Iregbu is Chief Consultant Clinical Microbiologist with the National Hospital Abuja in Nigeria, and he also lectures at the College of Health Sciences of the University of Abuja. He's the Royal College's country advisor for Nigeria and has previously worked with us on AMS educational activities. So thank you very much for joining us, Dr. Iregbu. We're looking forward to hearing your perspective from Nigeria.
A good day, everyone, wherever you are in the globe. I will try to avoid repeating what others have said in the course of this program. I understand I have just 10 minutes to run through the AMS in healthcare, secondary healthcare, looking at Nigerian perspective. I will just follow this brief outline, introduction, the overview of Nigerian health system, and I'll delve into the secondary healthcare system with respect to AMS, and then I will conclude very quickly. We've been told variously that AMR is currently of a global concern. And we know that with a lot of organisms exhibiting resistance to commonly available antimicrobial agents. And this is mainly encountered in hostile-acquired strains, although the community-acquired strains are also showing up strongly with resistance. And these are mainly driven by inappropriate prescribing of antibiotics. The WHO advocates the adoption of antimicrobial stewardship to mitigate the impact of AMR and probably reverse the process. So the ASP program is a strategy that involves the application of objective interventions to influence prescribing practices. In other words, ensuring responsible prescribing and use of antibiotics. And we need to understand that it is a multidisciplinary activity. It is not something for an individual or just a small cohort or group. It involves virtually every healthcare professional and some levels of administrations. Now, in Nigeria, we have this level of healthcare. We have 3 levels of healthcare, the primary, secondary, and the tertiary healthcare. Generally, the tertiary healthcare level is mainly organized by the federal government, although some state governments also have some input there. The secondary healthcare is mainly under the control of state governments with some level of federal government. And then, of course, the local government is supposed to handle the primary healthcare. Even at the way it is now, the federal government is also playing some roles at this level of healthcare, particularly in the areas of immunization and vaccine administration. Now, coming to the healthcare practice generally, the tertiary healthcare level comprises the teaching hospitals, which are both public and private. The secondary healthcare has the general hospitals, which are also public and private. Then, of course, at the primary level, you have mainly the health centers, the community water centers, and so on and so forth. Now, the primary healthcare center and the tertiary healthcare centers are mainly under the control of governments, whether state, local, or federal. Whereas at the secondary health level, we have the private sector coming on strongly at that level. And so you have majority of the secondary healthcare centers under private establishments. Now, talking about the AMS practice at this level, the secondary healthcare level, I must say at the beginning, right away here, that most of the activities of AMS in Nigeria at the moment are centered mainly at the tertiary level. So the secondary healthcare level has not really come up strongly to be involved. And so we have a couple of studies that reviewed the pattern of the antibiotic use and prescription, and the challenges and barriers against antimicrobial stewardship. Now, if you look at this first study by Meda and colleagues published in 2021 in the PMC, you find that the knowledge of AMR among healthcare professionals, was something below 70%, at about 64%. Nurses were far lesser than that, about 27%, and that does not show a system that is very vast with issues on ground. So you will expect that almost every doctor practicing an environment should be very conversant with antimicrobial resistance and the prescribing behaviors, but that is not the situation. Again, we had this study again in four government hospitals, mainly tertiary hospitals, published in the Nigerian Medical Journal, that shows the prevalence of antimicrobial prescribing in patients to be as high as 70, which means at any point in time, about 70% of patients in the admission were on at least one antibiotics. This is as part of the general feature that we found, including prolonged antibiotic use and lack of indications for prescribing in many cases. These are other studies that looked at the challenges and the gaps in antimicrobial implementation in Nigeria. And again, we found some very interesting developments there. I will just summarize them at the end of these studies that I'm showing you. Then we have another one in 2015, also 2018 rather, conducted in so many hospitals across some regions. Then we have all these ones. I'm just showing because there's no time. So these are some of the studies that have been carried out on AMS in Nigeria, looking at prescribing pattern, looking at challenges, looking at barriers, looking at the effect of the outcome of impacts. Generally, I can summarize these findings here. That would discover that 20 to 50% of antimicrobial prescriptions are either unnecessary or inappropriate. And very often, wrong antibiotics were chosen to treat an infection, and broad spectrum antibiotics were preferred to narrow spectrum, even when there were indications for narrow spectrum. We had issues of prolonged use of antibiotics, particularly in the area of surgical antimicrobial prophylaxis. In 95% of cases, the duration of prophylaxis exceeded the conventional 24 hours. And like I mentioned earlier on, over 70% of patients at any point in time admission were on antibiotics. And there was no regard or compliance with the AWARE classification that requires that 60% of prescribed antibiotics should come within the access group. We did not see this one in our studies. Again, found out that the most commonly prescribed antibiotics were mainly the cephalosporins, the fluoroquinolones, and the penicillins. In some cases, we also found the metronidazole to be involved, and we attributed that to use in gynecological surgeries, where gynecologists use metronidazole as part of prophylaxis for their patients. Again, intravenous administration of antibiotics seemed to dominate the route of administration. Even when there were no needs any longer for IV administration, they were still continuing. No guidelines in many places. Even in the few cases where there were guidelines, they were imported guidelines. So they weren't guidelines from local environment. We also noticed overuse of empiric antibiotic therapy with little or no utilization of diagnostic microbiome service, so that there was overemphasis on empiric treatment. Even in some institutions where there were good facilities for laboratory work, the clinicians were not very commonly associated with the use of those laboratories. And some of these laboratories, their standard of work was found to be suboptimal, and they complied not with any of the known guidelines or standards. Then those studies also looked at some of the drivers of inappropriate prescribing. And we were able to divide this into three main categories. We have challenges from the drivers coming from the physicians with respect to knowledge and attitude. Quite a good number of them lack the necessary attitude and knowledge required of a physician to prescribe appropriately. Patients also, based on culture, socioeconomic status, levels of education, also contributed to inappropriate prescribing. Of course, at the secondary care level, where we probably are talking about today, leadership was a major challenge. We had very complex system of leadership and people who were really not in tune with the realities of the day. And so we look at these three levels of drivers. And for the physicians, what you need is a lot of education for behavior. That's what is about. Getting people to do things better, what they are doing to do it better. For the patient level, we need to create a lot of awareness, which we have started to do. Also started to educate some of the clinicians and also paid advocacy visits to some of the leaders of the healthcare system. I must say at this point that we actually have not been able to separate some of this in between tertiary and secondary. But like I said at the beginning, most of our activities have concentrated on the tertiary care levels, with the primary and secondary healthcare level just trying to come up at the moment. So they are far behind what is happening at the tertiary level. So talking about challenges, again, we have daunted by obsolete and equipment, sometimes unavailability of relevant equipment to do good work. We have issues of erratic drug supplies. You have a situation where pharmacists are lacking in very important drugs, therefore making it possible for patients to go out and buy whatever is available at whatever dose or quantity they want to buy. And these things are available across the counter with or without prescriptions. One of the biggest challenges we have today is the issue of human resource. It has been there for a while, but now it's getting worse with the immigration of our young professionals to UK, US, Australia, and other areas considered as more viable than we have at home at the moment. Then we have shortage of basic amenities like water and electricity. Today, electricity is one of the biggest challenges of our healthcare system. Today, as I'm talking to you, it's a big, big issue today. Of course, the health systems are poorly funded. So not until the issue of framing fund came up, no government, as far as I'm concerned, or I know, ever budgeted money for containment of antimicrobial resistance or funding of antimicrobial stewardship. I think everything that is being done today and from the governmental side is coming from this Fleming Fund and some other friendly organizations outside. Like I said, management either have to give no support or completely ignorant of what is happening. So you hardly find them supporting AMS activities because to them, it does not bring in cash into their purse. Prescribers' poor attitude and knowledge. The information management system remains manual. And of course, that is associated with poor records and documentation. So it's very difficult for you to go back and look at trend, based on existing record. This is some most places they are not available. Lack of community participation and ownership. Of course, the private sector, like I said, seems to be dominating the secondary healthcare level. But then they are not involved in any government policies as far as healthcare is concerned. So every attention of government is concentrated on government-owned establishment. The private sector are on their own, doing whatever they believe is right, with nobody looking at what they are doing as a matter of fact. Of course, they will have this issue of poor referral system. So all these ones put together, the drivers and challenges, making it very burdensome for antimicrobial stewardship to be established at these levels. So what are we doing? Well, we have not folded our hands watching events move on. Like I said, until the Fleming Fund came up, there was really no involvement of government in any of these activities. So what we did as a professional group, the Clinical Microbiology and Infection Society of Nigeria, we took it upon ourselves to develop a manual, geared towards helping health centers at all levels, both primary, secondary, and tertiary, to establish, sustain, and manage antimicrobial stewardship at their various centers. So this document was produced and launched in November last year. We are preparing to publish it in small copies and also upload it on our website whenever it's ready. So we have taken this bold step to be able to bridge the gap, because we've covered that many centers that wanted really to start off stewardship didn't quite know exactly how to start it and where to start it. And so we had to produce this document as a guidance document that will help centers to define their own direction and the area they can start very easily. And the other things that we have been doing so far include advocacy to chief executives of hospitals to let them understand what AMR is all about and how AMS can assist in containing the impact of AMR in the system. We'll also be educating our colleagues, clinicians, pharmacists, and everybody concerned with AMS using different fora, particularly during conferences and the scientific meetings. We find opportunities to put in some programs there to educate people on these aspects. We also organize some workshops and trainings with same focus on prescribing, because that's a major issue. We discovered that lack of knowledge is a major problem, and you do not expect somebody who has no knowledge of something to do something in that direction. So we felt that we need to empower people with knowledge before they can begin to comply with whatever prescriptions you may give them. Again, the issue of AMS and AMR have been well incorporated into our training programs for our undergraduate and postgraduate medical students, so that it's better to catch them young. When they are trained at this level, they are bound to comply or practice such practices when they graduate eventually. There are mentorings going on from some teaching hospitals that already established their AMS program, trying to mentor the lower ones to come up on board. Then, of course, like every country has done, AMS is one of the components of the National Action Plan for Nigeria, and that is being implemented by the NCDC. So that's under governmental control. So in conclusion, I will say that the secondary healthcare level in Nigeria is here to significantly embrace AMS practice due to many daunting challenges I've outlined previously. And the societies like Limison have been at the forefront of championing this AMS in the country, but much more is required than what we have done so far. So all stakeholders, healthcare providers, hospital administrators, policymakers, and even patients need to work together to establish and sustain effective antibiotic stewardship programs at the secondary healthcare levels. And when that is done, we are likely to improve patient outcome, help combat antibiotic resistance, and of course, decrease cost of care at these levels. Thank you very much for listening. Over.
Thank you very much, Dr. Irekwu, for so eloquently outlining the challenges in Nigeria and also some of the progress that you've been making. Thank you very much. Now, on to our next speaker. In fact, our final speaker of this session. And I'm very pleased to introduce Dr. Andres Perez Lopez, who is going to give us a perspective from Qatar. Dr. Lopez is Senior Attending Physician in Microbiology in Sidra Medicine in Qatar, where he's a member of the Antimicrobial Stewardship Committee and has published widely on molecular characterization of antimicrobial resistance mechanisms in pediatrics in Qatar using whole genome sequencing. Thank you very much.
Thank you very much. So hello, everybody. So first of all, I'd like to thank the RCPAC for the opportunity to participate in this excellent webinar to share with you guys what has been our AMS journey. So I have nothing to disclose. So to start with, let me give you some historical context. So in Qatar, the Ministry of Public Health mandated to the governmental hospitals to establish antimicrobial stewardship programs in 2017. So the first formal antimicrobial stewardship program here was implemented by the hospitals managed by Hamad Medical Corporation, which is the main healthcare provider here in Qatar in 2015. So here in Sidra, we are essentially a 400-bed women's and children's hospital. We are the main referral center for the whole pediatric population for the medical specialists, including oncology, neonatal intensive care, pediatric intensive care, and also surgical subspecialties like, for example, neurosurgery, cardiac surgery, meaning that we deliver tertiary care. So we have been here in SIDA functioning at a full capacity since January 2018. And so our antimicrobial stewardship program is essentially based on three fundamental pillars. The first one is pediatric infection diseases, which are they are the prescribers. The second one is clinical pharmacy, and the third one, of course, is clinical microbiology. So, so the antimicrobial stewardship team comprises so healthcare practitioners from all these disciplines. And I would like to summarize, to briefly summarize the activities that we carry out based on these three pillars. So from a clinical standpoint, so essentially we perform box and drugs face-to-face multidisciplinary rounds on a weekly basis. We perform these rounds in general pediatrics, in NICU, PICU, and also in cardiac intensive care unit. So we also do daily bedside AMS rounds to review all patients on that are treated with antibiotics that are in a protected list, and also complex patients on antimicrobial treatment. We also do formal AMS consultations when they are solicited by primary teams. And we also develop and review all the clinical guidelines and policies related to AMS. So essentially here in SIDRA, our antimicrobial stewardship programs is kind of hybrid approach in which a handful of handshake interventions with no restrictive prescription advice is combined with the timeout policy, in which some antibiotics that are included in a protected list after 72 hours when they were first prescribed, they required a review by somebody from the AMS team, which is essentially a pediatric infection disease physician or a clinical pharmacy. And this approach is also followed with a different, variety of peculiarities depending the hospital or the government the governmental hospitals here in Qatar. So as you can see, this approach also somehow is not far away from the one followed in the UK. So I'm talking about the STAR SMART and then focus, in which our clinicians are encouraged to start patients on broad spectrum antibiotics without any delay, followed by, the de-escalation or discontinuation or optimization of the antibiotic treatment based on some diagnostic information, clinical improvement, and also the review of the AMS team. As I mentioned, one of the activities that we carry out here is the development of guidelines. So currently we have approximately 15 guidelines that are our primary responsibility. I'm talking about the antimicrobial stewardship team, because there are other many guidelines that are not under our responsibility that we also collaborate with. And this is one of the ones that we constantly update, which is the list of the protective antimicrobials. As I mentioned, we have a timeout policy when these antimicrobials are prescribed after 72 hours for the clinicians to continue with the prescription. So these patients treated with these antibiotics have to be reviewed by the AMS team. So this is, we have recently updated this list, because as you can see here in the list of antifungals, we only include amphotericin B, caspofungin, posaconazole, and voriconazole. We have recently added to this list of protected antibiotics also other echinocandins, micafungin, and amidalofungin. So pharmacy-wise, so we also monitor and report the antimicrobial consumption data. This is one of the KPI indicators that we have to report on a quarterly basis to the Ministry of Public Health. So essentially, we report antimicrobial consumption on days of therapy per 1,000 patient days, which is the standard metrics used in the pediatric populations. You know that in the adult population, you normally use DDEs. The other activity that we perform in combination with pharmacy is policy compliance and AMS intervention audits. For example, we have recently completed an audit on the use of antibiotics after normal vaginal delivery and just check the compliance with the policy regarding the antimicrobial prescription in third and fourth perineal tear repair. And the other activity, the other important activity that pharmacy perform here is the formulary review and update. I can give you an example. So recently, we discussing the Antimicrobial Stewardship Committee that we also meet on a quarterly basis, the need to introduce some new antibiotics to treat some patients that have been evacuated from Gaza. So far we have received here in Sidra in a collaborative effort with the Egyptian government. We have received 150 patients since mid-December with war-related injuries. So some of these patients were transferred with some serious infections caused by, for example, carbapenem-resistant Acinetobacter, which is an organism that is not normally seen here. So we discuss based on some whole genome sequencing data and some phenotypic data, which actions could be implemented for the treatment of these infections, and we decided to include in our formulary minocycline and cefiderocol, which were antibiotics that so far they were not available in the country. So I can give you some examples of how we report antimicrobial consumption here in Sidra. So for example, we observe almost a 10% decrease in antimicrobial consumption overall between 2022 and 2023. Again, as you can see, we reported on days of therapy per 1,000 patient days. So we also observe a significant decrease in the consumption of carbapenems and aminoglycosides, particularly amikacin, between 2022 and 2023. So essentially what we saw is an increase of the consumption of all these antibiotics in Q3 and Q4 in 2022, but from the first quarter 2023, we started observing a significant decrease in antimicrobial consumptions. This is, for example, also the figures for glycopeptides, teicoplanin, and also vancomycin, and also cefepime, which is a 4th-generation cephalosporin, which is not available in the UK, with anti-pseudomonal activity. Of course, microbiology is fully integrated into the AMS program here in our hospital. So we have developed some rapid diagnostic assays. We also have cascade reporting policy. So we selectively report antibiotic susceptibilities based on our guidelines and also based on our local susceptibility data. We produce every annual cumulative institutional susceptibility reports. We, of course, do diagnostic stewardship. And we do characterization here. We do molecular surveillance of antimicrobial resistant mechanisms by whole genome sequencing. And since here in Sidra, we don't have adult ID specialists, so essentially the AMS advice given to the obstetric population is essentially given by us, by the microbiologists. So essentially we follow the same approach. We follow a handshake advice with no prescribing restrictions. And I can say that so far that our OB-GYNs, they are very happy with this. So let me give you an example of the rapid diagnostic test we have implemented so far. So this is our approach when we have positive blood cultures. I have to say that in our institution, so positive blood cultures are processed 24/7. So meaning that all these protocol is followed by the night shifts as well. So initially, when we have a positive blood culture, so a part of the gram stain, we perform also direct identification by mildly tough using an in-house protocol to prepare a bacterial pellet, something similar that some hospitals in the UK have done. So a provisional result, a provisional identification is given in between 30 and 60 minutes. Then we also provide some resistant markers by doing ESBL and carbamidase detections using lateral flow. And also when we have staph, so we also perform lattice agglutination assay to detect PBP2, I mean, to see if that staph is an MRSA. And also, so that result is also, that provisional result is also released in between 60 and 90 minutes. And finally, we also perform on that bacterial pellet, the same, everything is performed on the same pellet that has been processed using our in-house protocol. So we also perform direct thinning so that some susceptible panels, so provisional susceptible panels are available between 12 and 18 hours. So this is our experience using these protocols. So the first study you can see, so essentially we validated the protocol on 530 positive pediatric blood cultures, but also we assessed the clinical impact of our protocol. So essentially what we saw is a great impact essentially on the contaminated blood cultures. We noticed that roughly 50% of the contaminated blood cultures, so antibiotics were discontinued or withheld. So I can give you an example. For example, when you have a positive blood culture with gram-positive oxide in clusters, and you have a patient with multiple comorbidities and central lines, so there is always, the uncertainty that these gram-positive oxide cluster could be Staph aureus. So when we report in 30 minutes a coagulase negative staph, that essentially allows the clinicians, many clinicians essentially, to discontinue some empirical antibiotics started or to optimize the management by de-escalating. So the other thing that we saw in this study regarding clinically significant bacteremias, bloodstream infections, is, I mean, we only see an impact on 10% of those bacteremias because here in our setting, so 30% of the bloodstream infections caused by E. coli and Klebpneumo are essentially caused by ESBL producers, while also 30% of the Staph aureus bacteremias are caused by MRSA. So, I mean, only with when, for example, you have a provisional identification with a group-based strep, so that patient can immediately put on penicillin and clindamycin. But obviously, when you identify E. coli, Klebpneumo, or Staph aureus, and you're giving a limited information, that's why we decided to implement the second study. So long story short, so before the pandemic, we started to introduce some lab-mediated isothermal PCR, which is essentially almost a point-of-care testing for the detection of ESBLs, carbaminemases, and also MRSA. But due to some budget constraints at that time, because this is a molecular test and it's not particularly cheap, we have to move to a cheaper options, and then it was when we decided to implement the immunochromatography for the detection of ESBL and carbaminemases, and also the lattice agglutination for the detection of MRSA. As I mentioned, we also perform here a molecular surveillance by doing whole genome sequencing. So we know, based on our studies, that the molecular epidemiology of carbaminemases here in Enterobacterales in the pediatric population of Qatar is largely dominated by NDM producers and OXA48 producers. And also we know that the molecular epidemiology of ESBLs is largely dominated by CTXM enzymes, essentially CTX-15. But we also, performed a lot of molecular surveillance by whole genome sequencing, also for Hamad Medical Corporations. So, for example, you can see here on your right hand side. So we performed this study when we characterize an outbreak of Candida auris in those units dedicated to the care of patients with COVID-19 infections during the pandemic. And essentially what we saw is essentially also the molecular epidemiology of Candida auris here in Qatar is dominated by one clone, which is the South Asian clone, the clade 1. And we also managed to detect some novel point mutations that could probably be linked to the resistant to echinocandins and also some azoles. Of course, we also, as a part of the Antimicrobial Stewardship program, we produce the annual antiviral. As you can see here, we divide the antiviral in the pediatric antiviral and the obstetric antiviral. And in just both antivirals are divided in a kind of general antiviral and the urines antiviral. And the reason why we have these two different antivirals is because we observe a significant difference in the susceptibility patterns of E. coli and Klebsiella recovered from urinary samples in the obstetric and the pediatric population. So essentially what we have seen, consistently over the last 5 years is the proportion of isolates susceptible to beta-lactams, aminoglycosides, trimethoprim sulfa, and Cipro is significantly higher in the obstetric population compared with kids. And that the proportion, for example, of ESBL producer is significantly higher in the pediatric population. And I can explain you why, because essentially here in our hospital, as I mentioned, we are the main referral center for the whole pediatric population. So essentially we provide healthcare for free for a number of children with very complex and medical comorbidities that put them at risk for infections caused by multi-drug resistant organisms. By contrast, our hospital provides care for the obstetric population that is chargeable. So essentially is covered by the insurance company. That's why our obstetric population essentially comprises ladies with low-risk pregnancies. That doesn't really poses a major problem for the isolation of multi-drug resistant organisms. And that is my story. Thank you so much.
Thank you very much for that very, very interesting presentation from Qatar, which I'm sure everyone found as interesting as I did. We only have a very few minutes left for Q&A. We've had such brilliant input and content from across the globe that hasn't left us with very much time for the questions. Before we get into a couple of very quick questions, we have a brief poll that we'd like you to answer to let us know which country you're joining the webinar from. So we will leave that up, and please do enter your country in that poll. But in the meantime, I will carry on with just a couple of questions. And I'm afraid that, as I say, because we've had such a wealth of interesting content, we won't be able to cover all of the questions, I'm afraid, as time really is running out. But I'm just going to pick out a couple of questions very quickly. And the first one I'm going to select is the very first question, which is to Julie. It's talking about the antimicrobial prescription that you were talking about. Are there any downsides in terms of antibiotics falling off the chart because the prescription chart restricts people to 3 days? Has that been a problem?
It has indeed, and it's been the kind of biggest concern around this, and the balance in the risk between antimicrobial stewardship and effective antibiotic treatment. And we started with a 7-day administration section, and we had those concerns then, and we have moved further along to 3 days now. And so it's really down to training. We're lucky that the chart is used across the whole country in Wales, and so there's familiarity with it. But we really need to bring on the nurses, the pharmacists, as well as the prescribers to ensure that everyone is aware of that risk, particularly around weekends where there is less staffing in the hospitals, and trying to get it embedded in practice that antibiotics are reviewed before the weekend to stop that, stop inadvertent misdosing happening over the weekend. And one of the things we did do with the chart development was it used to stop after 3 days, and we changed it to stop after 3 days in one dose, so that the morning dose could be given in the working day, and that allowed then better follow-up to prescribers to get them to re-prescribe before any doses were missed. But yes, definitely an issue that we're continuing to be challenging around, but I think the success of the approach in reducing antibiotic kind of mitigates that risk, and also there's risk of antibiotic continuing longer than they need to as well, and so a balance of all that.
Thank you, interesting, thanks very much. We'll be sending around a brief feedback form after this webinar, and we'd really appreciate your feedback on the delivery of this session. It won't take long at all to complete, just a couple of minutes, and it's anonymous. And thank you to everyone who's attended in the audience. I hope you've found it interesting, and we hope to see you in the following webinars. Thank you very much.